So I'm going to start with Dr. Nora Leases. Nora and I have known each other for 16 years. I was an intern here and she was one of our senior doctors rotating in at that time. She is a world leader in many, many respects, but the thing she's most known about around the world is for immunotherapy. She has created a number of vaccines in our laboratories. Some of them have reached clinical trials. Patients fly around the world to get on these trials, and she's really a rock star.
So today I'd like to talk to you about immunotherapy and breast cancer. And VK ended with saying that we're starting to look at targeted therapies and immunotherapies right now. And I can tell you that 10 years ago when I would talk about immunotherapy for breast cancer, it was more pie in the sky and I'd show you a lot of mouse data. But now I can show you data that we're really generating in patients with breast cancer and some of the things we're learning about the immune response to breast cancer. So we know what we need to generate clinically effective anti-tumor immunity. And the way we know this is by looking at that panel, a specific type of immune system cell that's been able to be driven to your tumor. We know that if we have a high level of type 1 T cells, these are T cells or lymphocytes, they're part of your white blood cell count, both a type called CD4 and a type called CD8. CD4 T cells that are type 1 T cells secrete special hormones for the immune system, and they really create a danger signal in the tumor and a lot of inflammation. And CD8 T cells, the other type of type 1 T cells, they're called cytolytic T cells, and they have the potential to directly kill your tumor. So if you have lots of those type of T cells in your tumor and they're able to penetrate through the outer coating of the tumor and be found deep in the tumor bed, if you have very limited disease, like stage 1 or 2 disease, you're in that group that's never going to relapse your disease. And even if you have metastatic breast cancer, if you have these type of T cells in your tumor, we're studying whether you're in a category where you're going to have a much longer survival than those patients who don't have these T cells. This figure is from colon cancer. And in fact, now looking at T cells in colon cancer is going to be part of the staging system. And there are lots of studies going on to see if looking at T cells in the tumor are going to be part of the staging system for breast cancer. Because we found that if your tumor contains more than 50% of the tumor is filled with those lymphocytes, that you may fall in a better prognostic category. So what do we see in breast cancer? And these are these two panels. We see that although most breast cancer patients, if you look at the gray at the top panel, almost 80% have some level of immune infiltrate, meaning that your immune system is recognizing your tumor. When you look at those patients that have greater than 50% lymphocytic infiltrate in their tumor, it's really only about 15%. And this is data that was generated by Sasha Stanton, who's here today, who's going to talk about HER2-positive breast cancer. When you look at your tumor, looking for those killer T cells, those CD8 cytolytic T cells, only about 40 or 50% of patients even have one cytolytic T cell in the tumor. So we know that one of the biggest problems in the immune response to breast cancer is there's just not enough of it, right? And we also know that each individual subtype, triple negative disease, HER2 positive disease, and estrogen receptor positive disease, or hormone receptor positive disease, each have a different level of immunity. So let's talk about how we're using immune therapy in each one of these categories. So triple negative breast cancer happens to be the most immunogenic tumor. So when you look at that lymphocyte predominant breast cancer, the people who have 50% of their tumors infiltrated with T cells, most of those, or a lot of those, happen to be in the triple negative category. But one of the problems that we have in the immune response, if you have a rip-roaring immune response or a good immune response, immediately the tumor tries to get around it. And one of the things the tumor does, and this is in the far panel, is it upregulates these proteins called checkpoint inhibitor proteins. And as soon as the T cell begins to attack the tumor, these proteins become upregulated on the tumor and they block the T cell. So the T cell can't get at the tumor. And what VK brought up, some of these MAB-type drugs, is that investigators have made monoclonal antibodies that have been able to block the blockers. And so these monoclonal antibodies, when infused into patients, will block these proteins so that the T cells don't get blocked and they proliferate and they kill the tumor. And we've seen these immune checkpoint inhibitor monoclonal antibodies make an incredible difference in the treatment of diseases like melanoma and non-small cell lung cancer that, kind of like triple negative breast cancer, are what we call inherently immunogenic. They're filled with a lot of T cells. So there are T cells in the tumor that we can unblock. And so people have started using these immune checkpoint inhibitors specifically in triple negative breast cancer. And what I'm showing here is the first study that was published looking at metastatic treatment refractory triple negative breast cancer. Most of the patients, as you can see, had multiple regimens. And the response rate was about 20% of patients had responses, and so their tumor shrunk. And in fact, we've seen that a small handful of patients, maybe about 2%, even have complete responses. And the difference with immune therapy compared to chemotherapy is you see in that top panel, the time to response takes a very long time, and the tumors slowly shrink over time. And that's because we're not directly killing the tumors like cytotoxic chemotherapy. Rather, the immune system is growing, unblocked, and slowly killing the tumors. So much like VK said, we're hoping that this combination of these checkpoint inhibitors with different types of chemotherapy and other targeted therapies will convert more people into those slow responses and complete responses. So let's talk about HER2 positive disease. I think the biggest thing that we found out about HER2 positive disease in the last 5 years is that the immune response that's generated with drugs like Herceptin and pertuzumab is very important in terms of causing an anti-tumor response. And in fact, there have been many studies, and in the far panel I'm showing you just one study by a group at University of Pennsylvania that looked at women who were getting trastuzumab in the neoadjuvant setting. And we know that trastuzumab acts somewhat as a vaccine. And so the patients, when they received trastuzumab, generated high levels of type 1 T cells that were specific for trastuzumab. And the higher the immune response you generated, the more likely you were to develop a pathologic complete response after neoadjuvant chemotherapy. And so we know that it's very important to have a very active immune response when you're getting trastuzumab. But these studies done in earlier stage disease were not really applicable to later stage disease. And in studies that we've done looking at stage 3 and 4 disease, only 40% of patients who get trastuzumab actually develop the level of immune response you need to potentially contribute to the anti-tumor response of trastuzumab. But in this case, vaccines have been developing targeting HER2/neu, where we can give you a vaccine to try to help boost the immune response. And now there are multiple studies. In fact, there are 2 new trials that are going to start in 2017 from the University of Washington in combination with the guys at UPenn to see if during trastuzumab therapy, right at the time of diagnosis, we can start boosting immediately in more advanced stage disease to convert more people to having high levels of immune response using combination vaccine and trastuzumab therapy. And when we've done this on a small scale, you can see we can convert almost everyone to an immune response with trastuzumab with vaccination, and even boost 80% of those who developed immunity with trastuzumab by adding a vaccine. And this is data from a recent phase 2 study we completed in 38 patients with metastatic breast cancer when we gave the vaccine with their primary treatment. And as you can see, we're several years out and we still have many people who are doing well, and the median survival has not really been reached from this study. So we're very hopeful now going into randomized phase 2 studies that this vaccination with trastuzumab may become a good therapy to give in patients with HER2-positive disease. Finally, with estrogen receptor-positive disease, this is the least immunogenic tumor. So this is a category of patients where we find the most patients who don't really have any immune response. And we need to make the tumor appear more dangerous. So we can actually generate a type 1 signal. There are many different ways to do this with new immune therapies coming out. I'm showing you one strategy where many patients will relapse their disease in their chest wall. And we can take immune therapies and directly treat the tumor, in this case, a toll-like receptor ligand therapy that gives a danger signal and turns the tumor itself into a vaccine. So we completed a phase 2 study looking at giving this immunotherapy in combination with chemotherapy in patients who had chest wall disease. And we had very interesting responses, even though they'd been heavily pretreated in the chest wall with surgery and radiation. We had about 40% of patients developed a complete response with this immunotherapy, about 36% partial response, and you can see in a biopsy clearing of the chest wall and clearing of disease. And so this also is a strategy that's going to go forward into phase 2. And I just put 2 studies down here from our group that are vaccine studies that we've already started, and they're open for enrollment in patients with advanced stage triple negative and ER positive breast cancer. So again, you can just give me a call or contact me. You have my email. I'm easy to find if you're interested in finding more about these studies. So in summary, I think we're going to be seeing a new treatment paradigm for breast cancer especially. It's one of the most immunogenic tumors. We know most patients do develop an immune response to their tumor. So I think within the next 5 years, we're going to see people coming into the clinic with the first study being, along with deciding if you're hormone receptor positive or triple negative, how many T cells do you have in your tumor, and what type of T cells do you have in your tumor. And we're developing quite an armamentarium to be able to change the phenotype of the T cells and increase the T cells. And we know having T cells in your tumor helps augment the effects of chemotherapy. So when we get that data, which we know how to quantitate, we'll say, do we need to provide you type 1 immunity? Do we need to generate type 1 immunity? Or do we need to release your type 1 immunity, make it more functional? And immunotherapy, I believe, will be integrated right with initial therapy as standard of care. And the frontier now is figuring out how we make the immune response continue to grow and continue to grow until your tumor is completely eradicated.